Today's keynote is called Data Security and Privacy, the Foundation of Sustainable Strategies. And many of you attended the Health Tech Boardroom yesterday, and our organization is extremely passionate about security and privacy, mainly because of our history with government, and we saw what happens when organizations and industries rush to adopt technology without really doing their due diligence, and how those investments can impact security and privacy. And so we always make it a goal to really emphasize that element of IT and modernization efforts. So we've gotten a great panel together this morning to discuss that. Leading the panel will be Brian Selfridge, who's the Managing Director at Methodology Services. To Brian's left is Bree Jackson, the CIO for CalHIPSO, which is the California Health Information Partnership and Service Organization. And to Bree's left is Bill Vineski, the Executive Vice President and COO of Maricopa Integrated Health Systems. And I'm going to hand it off to Brian to kick things off.
Great. Thanks, Parm. Can you guys hear me okay? I don't know if the microphone's on. First off, good morning. I'm glad those of you that were able to make it through the trials of casino night and into an 8 a.m. session. Is everybody feeling all right? Do we need to do any of those jumping jack exercises or any of that stuff? Don't worry, I won't. Yeah, I know you just ate breakfast. So first off, I want to thank you for the opportunity to be here with you today on behalf of my organization, Methodology Services, and our partner, Ping Identity. I want to thank Health Tech Council for putting this together. I think this has been a great few days of discussion, learning a lot in all directions. Just as a quick housekeeping note, I'd like to keep this as informal as we can. To the extent everyone's not too hungover for questions, please throw questions out there, comments. We want to get good dialogue going and make sure everyone has an opportunity to participate. So we'll take a quick moment for introductions. I think is worthwhile. I can start and we'll go down the line. So my name is Brian Selfridge. For those of you I haven't met yet, again, I'm with Methodology Services. We're a healthcare IT security consulting organization. I joined on there about a month ago. Prior to that, I spent the last 5 years as Chief Information Security Officer for a hospital system in New Jersey. Prior to that, I worked for PricewaterhouseCoopers in our IT security consulting practice. So that's my background, and looking forward to some of the discussion. But maybe Bree, give a quick overview.
Sure. My name is Bree Jackson. I'm the Chief Information Officer for CalHIPSO. CalHIPSO is one of the... Good morning. Okay. Good morning. My name is Bree Jackson. I'm the Chief Information Officer for CalHIPSO. We're one of the largest RECs in the country. We serve 8,200 plus providers throughout the state of California. I'm responsible for the EHR adoption part of the REC program. I also oversee privacy and security, new business development, and physician strategies. I've been in healthcare for about 22 years, started first in the U.S. Army, and I'm pretty excited to be here. Thank you.
Good morning. I'm Bill Vineski. As Parham said, the Executive Vice President, Chief Operating Officer for Maricopa Integrated Health System, which is the public safety net hospital and health system for the greater Phoenix area in Maricopa County. We have a variety of primary and specialty clinics, as well as an acute hospital and a large behavioral health center. We're responsible for all of the court-ordered evaluations in the county, so that kind of keeps us very busy and fills up all 190 beds. In addition, I serve as the chair of the board of Arizona, of the Health Information Network of Arizona, the Arizona Health Information Exchange. We're not state-supported, but we are provider-supported. Participants include about 80% of all of the beds in Arizona, folks in Tucson, TMC, and Carondelet, UA Health Network, Banner, Dignity, my own hospital, Children's Hospital, Flagstaff, Yuma, and then most all of the health plans also belong to our exchange. So that we've experienced a lot there, and hopefully some of these questions can lead along that line.
Great. Thank you both for taking the time out of your excessively busy schedules to join us today. I know, for myself and the rest of the group, we're enjoying, hearing some insights and thoughts on your own experiences in some of these key data privacy and security topics. So maybe to level set before we get into some of the questioning, we're here to discuss privacy and security considerations, and I think from an organizational perspective, we're getting increasingly better ideas of the true high cost and significant costs associated with data breaches. We're watching the news, we're watching the HHS website day in and day out, seeing these multi-million-dollar settlements against healthcare organizations. Costs are associated not only in the regulatory fine side, but we're also seeing costs with having to pay for identity theft protection and some of the less tangible costs with reputational damage. I think we often forget that all that work we've done to build up trust with our patient base, with our customer base, one headline news item can erode that and really impact our customer loyalty and patient loyalty. So the impacts, the stakes are high from an organizational perspective for privacy and security breaches. I think we also tend to lose sight of the ultimate impact, though, which is to our patients. If you've ever been the victim of identity theft or know somebody that has, it's not fun. These data privacy and security breaches often lead to identity theft, whether it's credit card identity theft, medical identity theft, or just personal damage and some of the kind of embarrassment that can go with having your patient records made essentially public. So from an organizational perspective, we know that breaches can be costly, but I think we have to keep in mind the impact to our patients as well. So it's more than just about the data, it's about the people. So in the midst of this, breach environment, the potential for us to all have our organizations have these high-level, high-profile breaches, we're also in the midst of, as we know, one of the most dynamic reforms of the healthcare environment to date. That goes both for traditional reform, payment reform models, from moving from fee-for-service to bundled payments, accountable care. All of that requires data. It requires our data to be stored and managed in different ways in our own environments, shared with business partners, shared with across organizations. So anytime that we're deploying new technologies, HIEs, EHRs, analytics processes that we've been talking about over the last couple days, there's potential for breach and an increased potential for breach. So this is an evolving environment, and looking forward to discussing with the panel and with each of you some of your thoughts about how we can keep up with the changes, how we can focus on privacy and security, and to what extent we can prioritize it or need to prioritize it for our organizations. So that being said, maybe let's start with kind of a general question. We're toward the end of the year now, right? So we're going into budget cycles. We're going into strategy design for 2013. From a panelist perspective, curious, what are some of the top maybe 2 or 3 privacy and security initiatives or issues that you're looking to grapple with going into next year as you strategize and budget out for your organization?
Okay, I'll start. We just went live with our EHR in March, and just recently went with single sign-on too. It has posed some issues and some problems on the agenda for the coming year, not specifically to privacy and security, but looking at ERP and bringing that up as well. One of the real issues, though, is trying to deal with regard to the single sign-on, the ever constant flow of students, residents, and others throughout the system. We're an academic medical center, so we get the students from the University of Arizona School of Medicine in Phoenix, plus 2 or 3 other OD schools in town. Most of the nursing programs in town rotate through us as well. And they don't just come for 2 weeks and leave. They come for their rotation leave. They come back again. So we've had to deal with that, and we're just working on better processes to make sure that we can account for them when they're there, and make sure that they don't have access when they go away. The other concern we have is, of course, with the students, is the constant need for research, and research requires information. It doesn't necessarily require, PHI, but the rest of the information is there. So we're constantly working on that. Given the number of students that we have running through and the number of residents we have running through, we have to have a little more security on that, but nothing in particular that we have on the agenda.
Thanks.
My take on that is a little bit different. We have several large pockets of providers in California that are switching from some sense of a business management system that is not an EHR, and then they're moving into an electronic practice management system. So they would like to keep their original legacy systems. And so most of my focus is around identifying backup strategies for those practices, making sure that data lives in an environment that's easily accessible, that has low cost, that doesn't really put an impediment in front of that physician to move forward with their electronic health record. And then, of course, the other piece of that is most of these small physician practices and clinics, they don't necessarily have a chief of privacy and security, as you can imagine. So being a centralized resource for information for their privacy and security needs is another big task we've undertaken. We're working with the state of California has a communications committee, and so in that committee is a broad range of stakeholders, ranging from our deputy of privacy and security for the state, as well as other CIOs around the state. So making sure that that information, that ability to have a scalable solution in place for small and solo practices is a big initiative that we're working on.
Well, that's an excellent point, Bree. So along those lines, I've noticed that as well. There's kind of this gap between the level of security controls and protections you have in a larger organization where you have maybe a dedicated CISO or a security team or a full function build out, maybe governance process around security and privacy. For the primary care practices, smaller groups running their own EMR, running their own shop, any recommendations from your experience or thoughts you have about challenges for getting those particular organizations up to speed, both just understanding what the regulations are and requirements and maybe what we can do to help kind of bring them along as well?
We created roadshows, and we also created town halls where we're around the state talking about privacy and security, which is not in our scope of work. So if ONC is in the room, that's an additional cost that the RECs bear. We created these roadshows and kind of town hall meetings to do education, but we find it really does live in the larger organization. So if that's a IPA environment, helping to create tools that are scalable. The other big hidden resource that we hadn't thought about, but it kind of came to us over time, is that most of these providers are associated with medical societies. And so it was not just getting the information into their practices, but it's also contacting their local medical society. Because we have such large pockets of providers, a town hall meeting that we planned for 100 turns into 500 providers within hours. We have high traffic volumes. And so just the quality of information had to be there because we're saying it over and over again. It came to us, I have to say that because it's just so funny. We had all these packets of materials, but it came to us that giving them a portal on our website that they could come to as a member of the organization was also a good thing. So on their portal, there was a baseline framework of information.
That's interesting because I think those techniques are something we could potentially replicate out. Any thoughts from the group here? Did anybody else share those challenges around small, getting security and privacy baked into small practices as opposed to larger?
I had a question or a comment about some of the small organizations I found necessarily don't see the value of those activities, they don't understand it. So I'm wondering how do you deal with that when you don't have a culture that really supports or understands the importance of security and privacy activities?
So more of a core educational requirement. Any thoughts on how to help get awareness and education out to those groups?
Well, I speaking from the Health Information Exchange side, most of the people that we're dealing with right now are either large groups, say 20 and more doctors, so they have a little bit of a structure to them. Our concern, though, on the HIE is that in dealing with the broader community, that we will have this problem because the participants, of course, sign their participation agreement. We all have all of the cybersecurity and cybersecurity insurance and everything else in there. But the the strength and the validity of that security is only as good as the weakest link. And if we have a physician practice out someplace that is not secure and is not educated, then that information could be available to just about anybody. And that is a concern for us. As I said, we haven't had to address it yet because we haven't signed up individual physicians to the HIE. Now, the rec in the state has, and they are working on doing a lot more education of the providers, trying to get them signed up to, the direct exchange, and also trying to get them to take on an EHR. They are only mentioning security, so I'd be interested to hear what California's doing so we could do the same thing.
That's a great question, Parham. With providers, we were interested what did motivate them, and I think what motivates them are a lot of things, but a place that was mutual for us to play in was around their business processes. So we went to their malpractice carriers. We started having conversations about SRAs and the value of SRA, and within the first meeting, the CEO looked at me and he said, but how do I know that your SRA really does meet our sniff test? So we took it a step further and created an SRA audit process. So we took our SRAs, we sent them up to a high trust certified vendor, and he vetted our materials, and we gave that back down to the malpractice carriers. So we're integrating the importance of this basically in all of their business processes. So whether it's their malpractice carrier talking about doing an SRA, if there's med societies are talking about doing an SRA, we're in partnership with CMA, which is the California Medical Association. They're talking about an SRA. So we're bombarding them really with information.
It's great. So to what extent, for those risk assessments, so what extent are they being driven by regulatory requirements to do a risk assessment, whether it's high-tech, meaningful use dollars, or is it more your own initiative of realizing that that's the right thing to do from an organizational risk perspective?
We're in California, so for me it's the right thing to do. Silicon Valley is down the road, and providers are being bombarded with different technical initiatives, from cloud computing to cloud sourcing, hosted EHRs in an environment with dual kind of systems. They have an integration from their hospital system and living in their office. So it was just the right thing to do in my environment. In addition to that, we also have large FQHCs. So it's not just small and solo practices. It's the large FQHCs, it's the CHCs, it's the public hospitals. California is comprised of all of those market segments within our REC program.
Great. So I keep hearing this theme of some of the connectivity and complexity around having to share information out across disparate stakeholders, different organizations, whether it's through a health exchange or just more internally within the organization. Maybe, Bill, I don't know if you could speak a little bit to some of the challenges with the health exchange side of the house, whether it's around managing disparate stakeholders and making sure that everyone has input into the process as you're building out those sharing technologies. Maybe we could start there. How do you keep everybody in line, make sure you get the right input from the right folks and a governance process to make decisions that will satisfy some of them?
Well, you create a bureaucracy. I mean, I hate to say it that way, but in order to ensure that everybody has input, actually our board for the HIE, any participant can be a member of the board, and if you want input, then you have to kind of ante up your own time and effort and be at the table. We have such a variety of participants, from Banner Health System and their 8 hospitals to the small rural critical access hospitals in the state, as well as the FQHCs. Some of these FQHCs are quite small and very remote, but they're also on the list to participate. We have not initiated the exchange with them, but they have signed their participation agreement. So, as we sit down to do our policies, the board approves all the policies. So when we looked at our policy for consents, when we looked at our policy for the cyber insurance, for any of the elements necessary to operate the exchange, all of that went to the board, and we had significant discussion. At the time, we probably had 25, 28 members on the board, and everybody had input, some more than others. Certainly, Banner's legal department is probably bigger than some of the hospital's staff. And so they can have a great deal of input and influence on the resulting policy and forms. But at the same time, then they can implement probably quicker, and in fact, they have. And so then that becomes a model for how we can do that throughout the rest of the state. There is a lot of concern, but we're working, again, with the Arizona Health E-Connection, our rec, they're working with the independent physicians and doing all of the education there. So as we sign on and bring on more of the independent physicians, then we're counting on them to do a lot of the education. They're going to have to accept our policies, and we have said to some of the newer participants who have not liked our participation agreement, and we said, well, but that's it. Okay, it went through all the legal people when we were creating it, and everybody had an opportunity to join in the beginning, and you didn't want to join in the beginning. There was some money associated with it, so some people delayed. But that was your choice, and now we've made this, and the rest of the participants agree to the policies we have and to this agreement that we have, so you have to follow it. And no, we're not going to change it just for you, because then we'd have to go back to everybody that signed. And it has been successful. People that have wanted to join have understood that and have made the appropriate adjustments on their side in order to meet our policies.
It's great. Bree, from your perspective, in terms of stakeholder management and some of the folks that you need to keep involved in the process, either from a security standpoint or just general governance, any thoughts from your perspective of how any tactics you take beyond and above what Bill has outlined?
I agree with Bill. I think we, with our HIE, and there's several in our state, I wish we only had one. There are several in our state at various stages of being live. I don't think they're all live. I think probably more than 12 of them are somewhere in the middle of the conversation. Several are right around our backyard. I think for us, we spend a lot of time, and I stammer just a little bit because we spent so much time at the REC level kind of being the convener. Because we are so large and we have so many providers, people see us really as an opportunity to kind of come and vet what they're thinking and vet what they're proposing. So we're constantly being bombarded by, a state initiative or an HIE wanting to test out some language in a contract. Recently, we're working with the HIE on privacy and security. That's such a big issue, and using our providers as a test pilot. We're working with the state around data analytics, and so we're doing a test pilot for that. So the buzzword in our office is the word called pilot. So when I think of stakeholder engagement, I think of how can we test this out before we get too far down the line in communication and we find out that we've wasted some money going in the wrong direction. Let's find out exactly what people want and what they're willing to pay for.
That's great. I think I agree with you wholeheartedly around piloting, testing out some of these approaches before they go live, doing pilot groups, doing focus groups, getting that input continually seems to be a practice I see a lot of providers doing. Now, I'm glad that you both have health exchanges. Maybe we can talk a little bit about some of your specific challenges there. We're here for data security and data privacy. I've seen health exchange organizations go through difficult grappling, particularly around sensitive data sets, so things like HIV information, STDs, genetic information in some cases. Have either of your exchanges or the many exchanges you have involvement with, has that bubbled up in those kind of governance meetings as a potential issue? And if so, any thoughts around what we can do to protect those extra sensitive classes of information?
I'll go first on this. I'm going to take the easy route, let Bill answer the hard question. Years ago, the good part about California is we have a tendency to play with the same players. So years ago, I was actually the COO of a health information exchange in Long Beach. And it was a contractor position. We took it on for a year to really look at their operations and start the whole conversation about pay for services, fee for services. The number one roadblock is what we're talking about now, which is the data, the privacy and security. And that's where technology comes to play, but it's more than that. It's about educating the people about the technology that you're proposing. Not every HIE is created equal, and I think you have to know exactly what your market is, what your participants want, and how your technology integrates or in some ways bifurcates their process. And so what I found out and learned in Long Beach, long story short, is that most of the hospitals were on board and their C-levels were on board, but it was really the physicians that didn't understand. And we had the hardest time educating the providers. And since we wanted that information to really flow in both ways, both from the hospital and also from those large clinics, it was a very difficult conversation. At my new role, I find that the HIEs are still having the same conversation, same players, same issues. It really is around the technology and how well you've educated your public. So in our work with the Cali Connect, which is now California eHealth Quality Check, and they are our governance entity, we're finding that they have the biggest challenge is stakeholder engagement, is finding ways to get their message out without then, in some ways, really giving out too much information that causes a stir, which then gives their stakeholder group a little bit too much to chew on before they're ready to roll out. It's like give them enough they need to know, but not too much before you're ready to actually move forward.
You know, this is certainly a big concern for us. There's a lot of need for certain information out there, and yet the laws, certainly in Arizona, our state law, prevents us from being able to widely share that. And I don't think there's been a unified approach on how we're going to do that. Banner has chosen not to send any information that is behavioral health oriented to the exchange, as an example. I already said we've got 190 beds that are full all the time. You know, we may have to do the same thing. The concern is that there are a lot of users out there that also need some of that information, particularly the medication reconciliation and even, you know, appropriately the summary lists for diagnoses. You know, one of the first problems we ran into was with the Pima County Corrections Department, who absolutely wanted information. They have 7,000 people that they see on a daily basis. And they wanted to be able to check on medications to be able to initiate or sustain treatment as necessary for the folks that are under their control. And yet we can't share some of that information, certainly HIV and the behavioral health information. So the psychotropic drugs and others are being sequestered right now. I read about the work that the VA did in tagging discrete pieces of information so that they could send everything up, and then you'd note that there's more information, but you'd have to have either a separate access or kind of a break-the-glass technology to get into that additional information, so it would not be available to everybody. But somehow we have to create a mechanism that, you know, I'm not a tech person, so my descriptions may be a little basic, but we need some kind of a pipe through the cloud so that we can get information from one person to the other person without everybody else seeing it or even having access to it. Because you know, certainly the folks that are diagnosed with some of our behavioral health issues are a little more transient than others and tend to go from place to place. And we have the frequent flyers in the ED, and it would be nice to be able to see what's happening with them in their history, because all we have is what they give us. And yet we can't have that information. We're struggling with this, actually, in the state right now. We're addressing normal ADT, normal drug, normal labs, et cetera, and we're trying to determine how best to handle the sharing of appropriate information when necessary for the rest of it. And if anyone has a solution or a technique that we can use, we'd certainly be interested. Yes. Yeah, we have it. We have it at the state level too. So I haven't looked beyond there. But our state level legislation, actually, we had a great deal of input into that. We started, well, ASHEC started in like 2008, working on model policies and legislation for HIE and for HIO and for privacy and security. In 2011, the state passed the law, and it was in opt-out law for general consent on sharing of information through an exchange. Much of the language in that law was developed by the Arizona Healthy Connection Board and their legal team, which was very good for us. It does mean, though, that it requires that we have certain size font, certain information in the consent form, that every patient needs to be advised that the information will be available and that you need a signature on that advice, and then they can opt out. They can opt out total, they can opt out by doc, they can opt out by encounter, and that information needs to get back to the exchange. And no information can be exchanged unless the provider has the consent policy. So it's complicated things on the front end. It will be very good on the back end. I mean, they'll be able to have control on the information, but at the same time, it won't be as significant. I think Banner in their first month found that fewer than 1% of the patients actually opted out. So we know that that's there. But the elements of the HIV information and behavioral health information are specifically prohibited.
I think that's the continual balance, right, between patient care requirements and balancing the security for the sensitive data. I like Bill's model. I've seen many organizations doing that, break the glass type of model, so the physician can see that the information is there in the critical urgent care situations, and they can get it if they need it. But the casual browser, the casual snooping individual, that having access to HIV information is not acceptable. So it's that constant balance and tug of war.
Well, one more. We're really intent on trying to maintain a single HIE in the state. And this particular issue with behavioral health is a problem. Many of the behavioral health providers, the non-SMI providers, are coming together, and they're looking for their own EHR. A lot of them are looking at NextGen, and we have a vendor that's being very active with that particular group of providers, talking about how they could set up an HIE then among all the behavioral health providers. And we kind of want to prevent that. I mean, not that we're going to gain anything out of having just one, but it's going to be a whole lot easier if it all were in one. So we're looking at ways. Sure, we can connect exchange to exchange, but we're still looking for ways, because it'll be better for the folks that are ending up in the ER if they can somehow have access to that information.
So this is interesting. We talked about consents. We talked about patients opting in for allowing organizations to share information across the continuum. But I'm more interested recently to see the patient portal aspect of that and the patient access directly. So it's more than just opting in to allow their information to be shared for care and treatment purposes, but we're now moving to a model where we want the patients to be able to access that information themselves, and certainly the meaningful use incentives in Stage 2 are pushing for certain levels of adoption around that. So I don't know, Bree, if you have any perspective on the patient portal side, whether it's from consent challenges to getting adoption levels up above that 5% threshold or whatever the initial stages are, or any other challenges on the patient portal side that you might be able to weigh in on?
Sure. For us, most of our IDNs are really driving that conversation. So the large medical groups, the ones that are more than 200 providers, are really driving that initiative. They're providing the service directly for physicians so that they can meet that measure. It's really is about, most of it is about increasing adoption and educating the patient. Most of our medical groups, I'm not sure how it is in your state, but those doctors are not exclusive. So they can belong to maybe 4 or 5 medical groups. So it's a matter for them of just managing that much data and having 4 or 5 different solutions for 4 or 5 different patient panels. I think it's just, as I look at their challenge, single sign-on will not resolve that issue. It really is a different business model for them, and they have to make a decision whether to upgrade their IT internally to match that need, or if they're looking to do something independent. And most of them are not in a position where they're looking to do anything independent. On the clinic side, I think the hard part for them will be they have several solutions within their offices, and as I talked to their CIOs before I left, it's not something they're really interested in. They feel that their patients, less than 10% of their patients would participate in a portal. So we're talking to their CMIOs around doing something that's disease specific so that they can drive adoption, and I think we'll probably get a little bit more traction on that. So taking a look at the FQHCs, having a portal specifically signed up for a specific disease and having a patient go there is a solution we proposed. I'm very active in this space because as I look at the FQHCs, they make up half of our RUC, so that's about 3,000 plus providers in that segment throughout the state, and it's of a huge issue. So we're looking at very disease specific to help them increase their adoption.
Well, I can go back to our health system side. We have adopted Epic, and Epic has MyChart, which allows the patient to get in and view their chart. Epic has an application now that it would even allow the patient to view who's looked at their chart in addition to the information that's on their chart. And we adopted Epic in our outpatient arena almost 3 years ago now. And since that time have been quite successful in getting people to use MyChart, despite the fact that almost 60% of our patients are Medicaid and another 30% are uninsured. They all seem to have computers or access to a computer. So it has been, I think we have 15 or 20% of all of our patients that have logged on and used the MyChart application. And I think that'll be essential. I agree, for hopefully we can establish something that patients with disease specific can get to a certain portal, at least get information, if not look at their own information so they can really understand what's going on, and do that within their provider base.
Well, this is interesting, and maybe I have a question for maybe the larger group or the panel, but it seems like the PHR portals are popping up left and right, and the payers have one, the provider has one, the HIE has a portal. What are we doing to manage making sure that the patient has kind of one relationship with their data in one environment, not having to have 10 or 12 or 15 different sign-ons? I don't know if we've even gotten there yet, or whether that issue has really reared its head yet, but it's something I wonder, are we going to face that at some point where the patients are just not sure where to go and get their information?
I'll take a stab while you all think. For us, it really is about, and it's going to sound really different, but it's about letting the people who own those relationships drive the conversation and letting the RUC program be of value. So in the world of IDNs, we show up just to advocate for physicians using health information technology. How that IDN decides to deal with their portal and their patient information is really unique to that organization. We hear the response from consumer groups, and quite frankly, I was saying yesterday, it concerns me because I think the consumers are ready to share their information. Some of them, whether it's posting it on their Facebook or joining very specific types of web pages and different organizations and societies. And I listened to that educated version of the consumer market, and I think it's less than 10%. I think that the consumer group in California, and I shared this with her, and I'm waiting for her numbers to come back to me. How many people in your group really want to share their entire health information? And what she said to me is that, this is a poll of people in the market, but a poll is very different than people signing up and using a site. And so what many of our systems are doing is they're testing this out to see how much information education is needed, because I think it's different for everybody. I think it's different. I think the best model for us is Kaiser in the Bay Area. And so we really do take, we have a partnership with Kaiser. I participate on one of their steering committees. And so we really do take our footing from Kaiser and say, let's give them what they need. But again, the key word for us is pilot.
I don't think the folks from ONC are here, but they created all these silos by making meaningful use specific to the adopter of the EHR. I guess the next round of meaningful use regulations would be more specific on the certified EHR technology and on the use by the patient. But you don't get the funds until after you do this, so we can get 10% of our patients using the patient portal on our specific EHR, and then we'll get the funds that help pay that back. But we'd be probably better off getting the funds early and really educating the patient and educating the staff about the benefits of having that kind of connection, even demonstrate to the patient before they leave that they can access and they can do certain things. We can't control hypertension among our patient population, despite the fact that we have patient-centered medical homes and the appropriate technology, simply because the patients don't take the drugs and non-compliant patients. But if we can get information to the patient almost one-on-one through our electronic technology, perhaps we could increase that. Am I worried about that? No, I'm worried about meeting meaningful use so I can get my money. I'm sorry, we need it.
Well, there's always the minimum thresholds of, compliance, incentives, and then everything else. Question?
I have a funny story. We have 10 minutes left, but I have to tell you this funny story. I was a physician strategist for many years for Sutter, and so I built physician foundations. One provider, I've continued to be his work wife because he's just a sweet guy. I go into his practice, and one of his patients is sitting there. She's about 67 years old, and she says to me, she says, Bree, Roger wants to exchange information, but I think he should fix his electronic health record because it keeps losing my lab data first. I thought that was a perfect story. She's 67 years old. The doctor she's been with for 30 years wants to exchange. She hears him say, I want you to start exchanging information. And she says, but fix his computer first because he keeps losing my lab information.
Well, certainly not a high level of confidence for, for her own practitioner. You have a question?
That's a loaded question. So I'll take a very short take on this, Brian. I don't, in my honest opinion, in years of watching health information evolve, I don't think we're going to see that convergence around EHR systems in the next few years. I don't think that will happen. I don't think that will happen because it's a business model and not about the technology. So there's a business of having interfaces. There's a business of having that be difficult. There's a business reason behind it. I think as providers become, and this is the world I live in as a physician strategist, I don't think that the physician understands exactly the importance of what you're saying. What he hears is that he has CMS wanting things to be a certain way for his electronic practice management system, and then there's the society down the road who wants to build an exchange in his local region, and he wants to also meet all of the objectives for the incentive payments. I think the best thing that he will do, like all of us, when there's too many priorities, you cave. And you cave to the thing that is easiest. And the thing that is easiest is to really pay that X amount of dollars and get that interface going so you can move on to the next thing. I think what I was hoping from ONC around the S&I framework, which I'm pretty sure you're aware of, is a group of states that came together and we're talking about standards. But just, I wish we would have it here. Someone should hear that. I think we should have it here. Because when you get on those webinars, it is an hour and a half of chatter about standards, and different people have different objectives. So we go from, no, it's HL7, well, you know, it's an ADT. And in the world I live in, I'm sorry, it's not that complicated. We've made it a longer conversation than we have to. So that type of energy in the marketplace, like any other market, healthcare is just one market. It's like that in banking. It causes the other side to not want to bring their best to the table. We in California have 14 EHR vendor partners, and none of our 14 EHR vendor partners want to participate with any of the HIEs in our area.
I apologize, we're at time. Thank you for those comments. I would also just add one additional comment from a standards perspective, you know, from a HIPAA privacy and security. Much of the industry we've seen is aligning toward the high trust framework, which is kind of a single set of rules to meet your HIPAA requirements, meaningful use, meet identity theft red flags, PCI payment card stuff. So that's one framework that we're seeing organizations start to align with, because the requirements are this broad, and until we start defining one rule of the road for different controls, anywhere from password controls to cloud security to everything else, that's one avenue that potentially helps. So we're at time. I want to thank everybody for taking the time to hear us out, and then on an early morning. Thanks to the panelists for some excellent insight. Really appreciated getting those thoughts, and look forward to continuing the conversation with you guys throughout the rest of the day.
Thank you, guys.